Magnesium, most disrespected electrolyte that we have. Hardest to measure of all the electrolytes, and can be used for asthma, constipation. We'll talk about that, and why it's hard to even replace it. Eclampsia. We need to replace our magnesium before we replace our potassium because it helps in repletion with our hypokalemia, hypercalcemia. It also can be used in pain management. For a time period, we're having a huge shortage of opioids in the US, sounds crazy as it sounds, and legal opioids. And anesthesiologists were using magnesium fusions at a high amount and rapid infusion to help treat pain. In some countries, this is what they use. Anesthesia will use this, and there's some good studies backing it up. So why is it the hardest to measure? Only 3% of the total magnesium in the serum. The rest is stored in the cells and bones. It's hard to get a good measurement of it. Magnesium blocks the MNDA receptor. Oral replacement is not great. So that's why you usually give it as a IV solution if you need to replace it quickly. Oral solution absorption in the GI is poor, can lead to diarrhea. How can I prove that to you? Is you can go to your local pharmacy and go buy a bottle of magnesium citrate. It sits in a bottle like this, has a nice lemon lime flavor, and drink it and see what happens. And then you can tell me if you're going to replace your magnesium levels on there. Because remember, if you have diarrhea, that diarrhea you're going to have low magnesium because you're going to be pooping out your magnesium. So go do that experiment today, the magnesium citrate, and see if you have any diarrhea, and then check your mag levels before and after. So what foods can be used to replete? Nuts, avocados, spinach. Remember, spinach doesn't have great iron in there. I know Popeye lied to you, so if you want to go ahead and sue him, it's not great for iron. It actually has oxalic acid in it, and it can inhibit iron absorption. So spinach not great for iron, great for magnesium, great for magnesium. So he didn't go singing about how he got his magnesium and did better and didn't poop on himself, I guess. I don't know. All right, the same patient. Gosh, this poor guy. I mean, this guy, it just kept going and going and going. So remember, he's a 47-year-old, and we talked about that he had alcohol withdrawal because maybe he didn't tell us everything when he was there in the hospital. 48 hours, he had alcohol withdrawal. And he had hypertensive emergency. Then he had PRES, which PRES and the hypertensive emergency probably went back together again. He had his alcohol withdrawal. Then he had this torsades, because remember, he was an alcoholic and he wasn't eating and drinking well. Now his tachycardia, elevated jugular venous pressure, and pulsus paradoxus. Pulsus paradoxus, what is that? We'll talk about that. And guess what? This is a real patient too. What is this? So we're in a CT imaging, okay? So now remember, CT imagings, for those uninformed, if you already know, I'm sorry I'm repeating this and you already know much better than me, is you're going through the scanner, your feet going first, and it's taking slices. Now it doesn't cut you, it takes slices, imaging slices. And there can be greater amount of slices depending on the quality of scanner that you have, et cetera, et cetera. And it's taking slices, so this is slicing through the body. So what we're looking at is a slice of the body, and we see the pericardium right here. So let me draw on this, okay? See, here's our heart. That's the outside of our heart. You see all this fluid around here? This is the heart. This is the fluid. That is a large pericardial effusion. I do want you to know is that CT imaging usually overestimates the pericardial effusion. The echocardiogram is a much better way to get the true volume of a pericardial effusion. Now, here also is in this gentleman, you can see these are what? This is pleural effusions. These are pleural effusions. You can make an argument that this was an aspiration event right here on there, but these were pleural effusions noted on that CT imaging. All right, so here's another image, and this is another person. We'll go back to our patient, but this is another patient, and they actually had a cardiac fluid malignancy. So they did a pericardiocentesis, so they drained the fluid out, and they sent it to the lab for cytology, and that cytology, this patient unfortunately had a cardiac malignancy, so they had in that fluid that they drained out. Now let's go back to our patient. This poor guy, 47 years old, that came in with PRES, hypertensive emergency, torsades, magnesium deficiency, and now we have fluid around their heart. Okay, so what's the pulsus paradoxus? Now we're going to draw on this board real quick and we'll look at it. So normally, what happens is when you breathe in, you have a decrease in blood pressure more than 10 millimeters on mercury on inhalation. So pulsus paradoxus. You breathe in, you have more than a 10 millimeters decrease of mercury on inhalation. So when you inhale, let's talk about this process. I'm inhaling. Your blood pressure goes down because the right side of the heart gets bigger. So think about it during inhalation right here. See this drawing right here? Right side heart, bigger, bigger during inhalation, right? Right side of the heart gets bigger. The left side of the heart gets smaller, smaller, smaller under the left side, right? When we're taking. If the heart is confined, so the heart has fluid around it, so it's confined, it's like its own little heart prison. Got a little heart prison because the heart is confined. The right side of the heart gets bigger, then squishes the left side of the heart. So when you go to breathe out and go over here, boom, it squishes the left side of the heart and it decreases the cardiac output. So decreased cardiac output, guess what? We already talked about this. Decreased cardiac output, decreased blood pressure. So you breathe in on inhalation. The paradox is the loss of the palpable pulse. So this is where you have the paradoxes. You breathe in and you have loss of a palpable pulse. Why do you have loss of palpable pulse? Because your blood pressure decreased, because you breathed in. Your right side got bigger and it pushed against the left side. The left side cannot expand outward like it normally can. So normally the left side can expand outward, but it's its own little heart prison, and that heart prison doesn't allow it to push outward. It's not nice, and it doesn't come out there. So when the paradox is an exaggerated drop in systolic blood pressure during inspiration. Well, that was a lot of words. Why are we going through all this? Because they like to test it on boards, because it's something that you can test bedside. Now you really can't, because you really need to have a manual cuff to do this. Finding a manual cuff in a facility nowadays is impossible. To find a manual cuff that works, next to double impossible. So in those little manual cuffs on there that you have, there's two little screws. You can go look at a manual cuff. Once you drop it, those two screws get out of alignment and it doesn't work. So you will drop those cuffs. People drop them all the time, and those screws have to be perfect. So basically you have to have a brand new cuff that's never been dropped, that's in perfect condition. Guess what? Your hearing isn't as good as it used to be. So unless you have an electronic stethoscope, you're not going to hear it as well too. So this is kind of dated to do this nowadays, but it loves to be tested on boards. This pulsus paradoxus. We're just going to beat this into the ground. So normal inspiration, decrease in interthoracic pressure. You're breathing up interthoracic. You have an increased venous return, increased RV volume, right ventricle volume. The RV shifts outward into compliant pericardial space. The paradox is the inspiration is decreased RV volume. The shift left due to the increased pericardial pressure. You're going to have decreased ventricle volume, stroke, and hypotension because it's going to have less blood to push out. Oh, I think we're done with that, right? All right, I know that's a lot. Poor guy. All right, now let's talk about tamponade. All right, interpericardial pressure exceeds the diastolic intercardiac pressures, leads to compression of the cardiac chambers, and limits diastolic filling, stroke volume, and cardiac output. We're back in that heart prison. So we have the heart, and we have the pericardium around there, and then we have fluid around that heart. Cardiac tamponade is a life-threatening condition caused by the accumulation of fluid. It can be blood, pus, can be anything, in the pericardial space, leading to increased interpericardial pressure, impairing cardiac filling, and leading to hemodynamic compromise. The most common etiology is this: cancer, uremia can do that, so you have to have very high doses of BUN. Your BUN has to be very elevated. Infection, we talked about pus can be in there. Trauma, iatrogenic causes, you're putting a line and you stab them and you cause a bleed. The clinical presentation is variable, but also includes dyspnea, tachycardia, hypotension, elevated jugular venous pressures, and muffled heart sounds. So what is that? That's a famous triad, Beck's triad. Hypotension, elevated jugular venous pressures, and muffled heart sounds. Why the heart sounds muffled? Because there's fluid in there and you can't hear the heart. Earliest findings, echo shows the right side collapse, which we discussed. The paradox is a later finding, but they love testing on that. You're going to have an increase in pulmonary capillary wedge pressure, leads to pulmonary edema. So you have increase in pulmonary capillary wedge pressure, leads to pulmonary edema. Treatment: IV fluid to stabilize, volume loading to increase cardiac output until pericardiocentesis or surgical pericardial drain can be formed. Oh, guess what? We're still dealing with this guy, the same patient. And I wish I could say that this was a fake story, but it's real. So we got the 47-year-old male. Blood pressure is elevated because he lied about his use of alcohol. He had a press. He had alcohol withdrawal. He had risk for refeeding syndrome. Then torsades because he wasn't eating well, and he's pooping out his magnesium. Now, and then he had the tachycardia elevated, and he had the cardiac tamponade. So he gets those things fixed while he's recovering. So he's been in the hospital, I think it was almost a month at this time. And guess what? He had left side upper and lower extremity weakness. Left side upper extremity, lower extremity weakness. So what happened? So we get the imaging into the supercomputer, and what does the supercomputer show? All right, let's draw on here. Look at fancy drawing. Look at that right there. That's blood. Okay, remember we're slicing. I know if you know this already, I'm sorry you're hurting your feelings. We're just going through and reviewing it, okay? Hurting your feelings because I'm showing you it. We're slicing through that cranium. The supercomputer right there, that's a different density right here. That's a blood. This is an intracranial hemorrhage. This is bleeding within the cranial vault. And his is an intracerebral bleed. There can also be subarachnoid. We'll go through the subdural and epidermal. It can be spontaneous, and it can lead to morbidity and mortality compared to an ischemic stroke. Increased morbidity and mortality compared to an ischemic stroke. Now, what do we worry about with this? Blood in the brain causes irritation. And we know this gentleman already had seizures, high risk for seizures. Anything in the brain can cause irritation, can do weird stuff. So how do we manage this? So this one guy, we're learning a lot, right? Well, first we want to hold anticoagulation, right? We don't want to give him any more. He's got enough. Blood pressure control, usually less than 140. Now, neurosurgery will tell you what they want, what they think is going to be the best. And probably 140 is going to be the best. We're going to reverse anticoagulation. Remember, for heparin, it's protanamine. Enoxaparin is going to be protanamine, doesn't work as well. We'll do the recombinant factor 7A. Aldox is up to bigatran and exidate alpha. Or you can use the 4-factor prothrombin complex concentrate. Why would the hospital want you to use the 4-factor prothrombin concentrate? Money. And they'll have it available. Exidate alpha, less likely to have available. Some systems don't carry the 4-factor, smaller systems, but more likely to have it. And then this is our guy in dabigatran, idaruxicabazine. I can't even say this one. I've given up. I'm not even going to try to say it right anymore. I'm done. So if you ever use dabigatran or dabigatran, you know that you need to use this. Okay, I'm done with saying it. Now, warfarin, you need to use this is what was made for the 4-factor prothrombin complex concentrate. Does well with it. You also want to give vitamin K. When you give the factor 4 with warfarin, you're going to see the INR drops rapidly. Then it can have a tail where it pops up, where basically the 4-factor, we'll say it kind of wears out and it has a tail. That's why you give the vitamin K. The vitamin K takes longer to get and starts working. So once it drops rapidly with the 4-factor, instead of bouncing back up, the vitamin K smooths it out. So you keep your INR low and normalized. And then you want to do intracranial hemorrhage score. These are things that you can look up. This is how you correspond with your neurosurgeons, because that's who you're going to have to call. And then you need to have a surgical evaluation. And if you don't have neurosurgery in your facility, you need to look at transferring them out to another facility that's able to support them. And you can give an intracranial hemorrhage score. Very easy to look up, very easy, because you need to be able to speak to the providers that you're giving things to. They don't want you to feel that you're a retard, okay? All right. Now, that guy, we're done, poor guy. Okay. Let's go with here. So we're talking about, this is a diffuse subarachnoid hemorrhage. So a diffuse subarachnoid hemorrhage is a stroke caused by bleeding in the subarachnoid space. Drawing, subarachnoid space. We're going to say it's over here. Okay. And it accounts for about 10% of all strokes. Usually affects younger patients. Mean age is 55, resulting, this is the big thing, significant loss of productive life and high mortality. Even to get to your facility is like a 50-50 chances they'll even make it there. The classic presentation is severe thunderclap headache. Described as worst headache of the patient's life, sometimes accompanied by what? Loss of consciousness, neck stiffness. Blood gets in that area, it stiffens up. Blood does not do well in the central nervous system. You can have vomiting, focal neurological deficits. Diagnosis established by a non-contrast head CT. If you give contrast, the contrast is going to look like blood. Contrast looks like blood, so you're not going to be able to get that diagnosis. It's highly sensitive within the first 6 hours of symptom onset. If it's negative, but you still suspect it, what do you do? If you think it's negative and it's still suspected, you can get a CTA, and that's going to get you up to 99%. Okay, you get the CT head and the CTA. If those are still negative, but you still suspect it, what do? Lumbar puncture, lumbar puncture. All right, so managing a subarachnoid hemorrhage. And I know we deviated from our cardiology. We'll get back to it. We're just kind of remember the patient has all sorts of things. It doesn't have our problem. It can have a head problem like our guy that we discussed. These cases, things happen to different systems and they all go together. So managing a subarachnoid, non-contrast CT, LP, CTA, CT angiography. This score you want to use for a subarachnoid is called the Hunt-Hess score. This is so you can talk to your neurosurgical colleagues. They're already going to think you're stupid, so at least have something so they think you're less stupid than you are, okay? You need to reverse the antithrombolytic therapies, BP lowering. We're going to say 140. Some of them will say 120. Some will say 160. Remember, neurosurgery, they're their own special beast, okay? We just live in their world. You want to give them nifedipine. We'll talk about nifedipine, okay? Important. And supportive care, they may need to get intubated. So we discuss bleeding the subarachnoid space, high morbidity, high mortality. So if you, remember, you do a CT head first without contrast because the blood looks like contrast. If and then you probably in your system are going to get a CT head, CTA. They're going to want a CTA because they're going to look and see where it's bleeding from. If those two are negative, it's 99% usually sensitivity, then you do an LP. You stab them in the back, right? Stab in the back, like administration stabs you in the back, you're going to stab the patient in the back. Hopefully you do a better job. And you're looking for what? Xanthochromia. What is that? It's a yellow fluid discoloration of the subarachnoid. And you're going to get that, you're going to send the LP down, and you're looking for this yellowish fluid, and that's seen in the lab. And you're going to have an elevated red blood cell count. That's why you label those tubes. We'll have a section on doing LPs. That's why those tubes come. There's 4 tubes. And if it's the same RBCs all the way through, do not decrease, it's a good sign for that. Xanthochromia appears usually 12 hours after hemorrhage and persists up to 2 weeks, making timing the LP critical for diagnostic. Now, distinguishing a subarachnoid from a traumatic tap on of the CSF, so you're going to have the high RBC count, the xanthochromia, and have elevated CSF white blood cell count, or more consistent with a subarachnoid hemorrhage. So you have RBC count that's staying consistent across the 4 tubes, xanthochromia, which you're going to see in the lab is going to look, and then the elevated CSF white blood count. So you already have a clinical suspicion versus a traumatic tap, meaning that you hit a small vessel where you're going in, where you're stabbing in the back. Well, administration is stabbing you in the back. So they're stabbing you in the back, and you're stabbing the patient in the back. Well, declining RBC count across the tubes and absence of xanthochromia suggests a traumatic tap, unless you really screwed up. So you should be decreasing across with a traumatic tap. CSF lactate dehydrogenase can also differentiate. Is this higher in subarachnoid hemorrhage? That's one of those things that you can check off on the box when you're getting the fluids down there. The Hunt-Hess score, which we talked about, is a clinically grading system used to assess the severity of the subarachnoid hemorrhage. And the Hunt-Hess system has been validated as a prognostic tool. Basically, how the patient is doing. It's very easy to do. If you look it up that way, and it tells you that morbidity and mortality, this will help you correspond with those animals called neurosurgeries. The animals called neurosurgeries, because they control the game. We just live in their world, okay? The Hunt-Hess score has been validated, and it gives lower grades at 1 to 2, and 3 and 4, they have increased morbidity and mortality. Nifedipine, what is this? Nifedipine is a calcium channel blocker, and it's initiated for improvement. It's indicated for improvement in neurological outcomes of those with subarachnoid. So what does it do? What does it do? It stops vasospasms. It stops vasospasms. So I want you to think about it as you have the subarachnoid hemorrhage. This brain is ticked off. You have this brain with blood in it, and it gets ticked off, right? So, and it starts spasming. And when it spasms, remember the brain doesn't do well when it doesn't get oxygen. So it spasms, it closes up, tissue dies. And if you keep doing that, you're going to have more spasms, you're going to have more stuff and more bad stuff happening. Nifedipine, okay. Nifedipine has a black box warning for what? do not inject this medication. It comes in a gel cap, and you can pour it down the patient's tube if they can't swallow, because most of these people are probably going to be in a ventilator, and you can put it down the tube. In the old days, when I used to manage strokes, remember, everything we do now is wrong, and whatever we did in the past was wrong. So what we do now is wrong, and what we did in the past was even wronger, is we used to believe in strokes is we need to get their blood pressure down. Came in at 200, let's get it down to 100. We're going to take care of that stroke. Well, we took care of that stroke, all right, but we dropped their blood pressures, and they used to inject the nifedipine. You may have some old nurses that are hanging around in your unit, and you could talk to them about, hey, did you inject the nifedipine? Oh, yeah, it was great. It dropped them down, and it dropped their pressures from 200 to 100 without even an issue. Didn't even blink, and they went down. Guess what happened is the strokes got worse. And we'll talk about this in the neuro section. We have to have some perfusion in our brain. So we used to knock them down. Remember, what we do is wrong is now, what we did in the wrong past is wrong is now, and what we do in the future will be wrong too. But we're trying to do less wrong. So nifedipine gives a black box warning. If you inject it, it will drop blood pressures. Even when you give this orally or through an NG tube or OG tube, is this going to drop the blood pressure? And you're going to see this pattern is that every 6 hours, and a few hours after that 6 hours, their pressures are going to drop because they received nifedipine.